We're going to have a panel at this time. So I would like to ask Dr. Karras, Dr. Lobel, and Dr. Galler to please come up. And then, is there any volunteer from one of our African countries? Anybody who wants to participate on this panel? We can add one more person. Anybody that would like to participate on the panel? Oh,
He's saying, you're here.
I'm here.
Oh, Sybil. You want to sit down.
So, let's give him a hand. He's such a good sport. He didn't even complain. He just came right out.
I asked him nicely.
You asked him nicely. So what we're going to be talking about is various surgical issues, and you saw how many different opinions there were. There's so many ways to do things, and let's have a discussion on some of those different ways of doing stuff. Thank you.
All right, thank you very much. My name is Timothy Abutu. I live and practice in Düsseldorf in Germany. So I thank you so much for having me. I have one short case on this topic, and you'll have to excuse me. I mean, once in a while I'll chip in some German. My English is a bit rusty, so just give me a push when you have a feeling I'm speaking German. So I'm going to have a panel.
He can speak in Dulu. Just your name and where you work.
Once again, same thing on you, the neurosurgeon coming from Canada.
Robert Howard from New York, United States.
Chris Harris from Ohio, United States. Jeff Lobel from Lima, Ohio.
All right, I just presented this picture. This is a 57-year-old that I saw about a month ago. He had 2 months ago L4 radiculopathy with pain in the right leg. PRT for L4 was done, after which the pain subsided. And then about 4 weeks ago, he developed foot lifting weakness of the right leg, power grade 3 to 4 from 5. At the time of presentation, he had no pain. So just for starters, maybe for the residents, because where the residents, maybe just pick up one. Samuel, yeah, Samuel. I met Samuel this morning. Sorry, Samuel, but yeah. So pictures are not so, but I think you can see. Where would you look if, let's say, somebody has a L4 pain on the right side? Yeah, what would you be searching for in the lumbar spine? Yes. Okay. There is some nerve root compression, isn't it? Yeah. So maybe we. Okay. Yes. Yeah. So do you see anything in this case? Let me see if I can get some better. Is there anything? It's most also the radiologists sometimes miss it.
Central stenosis.
Can you move forward just to let us?
Yeah.
I think it's central.
Come on.
Yeah. Yeah, we have a stenosis, that's right. A relative stenosis.
But I need to see the foreigners.
Yes, there is. Let me see if I can enlarge it a little bit. So these are the foramen. Those are foramen, yeah.
What is the line?
Yeah, the line is unfortunate, but I mean, you see that there's some kind of substance here. And so these are typical range of foraminal disc products, it's normally you have to most of the times you have to, if you're not experienced well enough, you have to look twice. So radiologists also tend to miss this in the practice. So when he presented, he had got a PRT of the L4 ton at this level, and he had no pain. The neurologist did electrodiagnostics, which showed a slowing of the peripheral perineal nerve, and no signs of weakness. That we did see even in the clinic, no signs of weakness of any of the medial gluteal muscle. Trendelenburg sign was negative. So we have an intraforaminal disc prolapse, L4-5 on the right side, no pain, but motor deficit for L5. So the question was, what do we do? Yeah. So maybe this goes to the panel.
This is a difficult case because when you have we're very myopic. You know, we have tunnel vision. We look at the central canal and we look at the foramina bilaterally, and they're patent. But you have to look at laterals of the facet many times. So if you say this person has a clear radiculopathy and the lumbar spine looks good, look lateral to the facet, and on the axial you'll see a big disc herniation. The reason it is painful and causes weakness, it can be difficult, is because when you're that far lateral, you're now over the dorsal root ganglion, which is very painful, very sensitive part of the nerve group. And in fact, decompressing a lateral disc herniation often doesn't have the same result as irregular disc herniation in the lateral recess, because the dorsal root ganglion is so much more sensitive, so much more difficult to improve over time. So for this, I would recommend surgery, typically.
Even though the weakness is for L5 and he has no pain.
Oh, he has no pain.
He has no pain because he had PRT done of an L4,
yeah.
And he came in painless, but he had a weakness, and the weakness wasn't typical L5 all through to the gluteal muscle. It was just foot. No, this is a foot drop.
And I would repeat the MRI in that case. Because this also is a very discrete lesion. You know, a lateral recess disc herniation can have L4 and L5 components.
Yeah.
Lateral should not have L5 components. L5 is the shoulder of the nerve root in the lateral recess at this level. And so I would repeat imaging if the symptoms changed and the exam changed that one.
I'll just say this, the imaging was really fresh. I don't have the dates, but this was the latest imaging that he had after everything was done. Yeah, so, I mean, some years back, I had a patient who had intraforaminal disc, a prolapse L3-4, and she had L5 pain. And we did PRT, and the pain subsided, and we decided to do surgery nevertheless, and she did quite well after surgery. She had no pain. It was one of those cases where it really doesn't fit into what you get in the textbook or what you have in your experience. So, any other suggestions or concerning treatment?
So forgive me.
Yeah.
PRT, if you could tell us what that acronym is.
Oh, so that's radicular infiltration therapy with steroids and
steroids.
Yes, sorry, that's German. Yeah. Okay.
So typically for a patient with acute disc herniation, that's pretty much the avenue most of us will take. It's a conservative approach with physical therapy and an anti-inflammatory, followed by consideration for epidural steroids. In this case, a transforaminal epidural steroid injection sometimes is more effective than a caudal because of the fact that the disc herniation is lateral. So that can be very focal and helpful. And that's probably why that works so well. And then surgery again will be reserved for refractory symptoms to all of these treatments. The patient can have persistent pain and or weakness, and sometimes atypical signs can occur. But I think that if all of the non-surgical methods have been exhausted and the patient is still highly symptomatic, then I think offering them a microdiscectomy is not unreasonable.
Okay, and Jeff?
One of the things in the U.S., at least when I see residents, that they lack is the art of physical exam. I work with a population of morbidly obese individuals who are conditioned to smoke who are diabetics. So if I get somebody who comes in with painless weakness, a red flag goes up. Because oftentimes we'll see radicular pain, but if somebody's got no pain or symptoms that don't quite make sense and an MRI that doesn't always jive, I have to look elsewhere. I look at the knee, I look at diabetic issues, and I look at peripheral vascular issues, because one of the things that you did was to have the electrodiagnostics at the knee. I've had people who come in with painless foot drops who had lumbar surgery for benign looking MRI scans, did not improve. Now we destabilize their back depending on how aggressive the surgery bothered. I look at the knee, I get a knee x-ray, I do the rest of the physical exam, and sometimes I just continue with conservative treatment. And I have, I'd say, about 20 to 40% of the time, people improve without a clear-cut explanation. Because as oftentimes we know surgery is not the answer for everything. The body is smarter than we are, and we forget that. And oftentimes also, about 80% of our difficulties with the spine don't have a clear-cut explanation. So I think a careful physical examination, at the very least an E-X-ray if it doesn't make sense to you, and also speaking with on physical, not so much the physical exam, but when you're interviewing the patient. I had a patient very similar to this who had some benign findings. I could argue to do a microdisc, came in with a painless foot drop. It started about a month prior after he went hiking for a period of time. And it was all because of common perineal nerve injury, which he experienced, and about 4 weeks later, his foot got better. So you can get these foot drops with improvement that don't want surgery. So I always caution people, history is very important, as is physical exam. Just because we're surgeons doesn't mean that we can't examine someone and only go through the MRI. So don't, if we're getting a curveball here, don't get sucked into it. Because once you do surgery on someone, this is for the residents in particular, at least in the United States, they're your patient. And now where Dr. Patel is, where they have signs advertising, injured during surgery, call 1-800, I got injured, that's for real. So you gotta be careful what the patient's motivation is, what they want to do job-wise, their smoking history. Gather all the information before you do surgery.
Okay, thank you. Any more questions from the audience? Okay, so I think this is a good case where the decision is split on surgical and conservative treatment. We were also split. I was more reluctant on doing surgery, but we did end up doing surgery on him. The foot drop did not improve, but everything's still fresh. So we will just wait and see how it goes. Yeah. Mm-hmm. All right. So then the next case. Excuse me for a minute. Yes.
While we're getting that to come up, did anybody have any more questions? Any questions to the panel?
I just had a question. As probably most junior attending in the room, and to not operate. How do you pick patients that you know will do well? Does that make sense?
Sometimes you think you're a really good judge of character, and you can do a perfectly well done technical procedure on what you thought were absolutely reasonable indications. and have a suboptimal outcome. And sometimes you just don't know why. I think obviously red flags always, the obvious ones that you don't have to be a senior neurosurgeon to know would be, in interviewing the patient, what's their motivation? Are they interested in being enabled or disabled? Do they have other issues such as litigation? Do they have other personal matters that make a difference in terms of what will allow them to recover? But for the most part, I think that the average person that comes in, you have to be on the positive side of things and think, all right, I'm going to do my best to help this person who wants to get better. But yeah, I'm still learning. I have patients that don't do as well as I would have expected, and I still don't know why. But fortunately, it is getting rarer. I think maybe the reason for that is because I've become even more conservative over the years, and I think that that's part of it. Less aggressive procedures and making my indications that much more firm.
And then in Africa, our population is quite young, so we don't have lots of staff that my colleagues have here. So I don't know whether Dr. Olomina will agree with me that what probably some of you see, you don't see it common in our center. I think because we have a young population, except if it's trauma related. But in a few cases, I'll also give an example of a 78-year-old female who had a fusion 1 level, fusion L1 and 2, because of, I think she had a osteoporotic fracture at that level, and she had low region on the right side. We did a CT MRI. She had a sequestered disc that was very clear at L5 as 1 on the left side, not the right side. So we had a case that was onto us, and we didn't know sincerely what, because the symptoms were not matching what the imaging was giving us. And over time, I think initially we managed conservatively, then when we repeated the scans, that is the CT, we realized that one of the lower screws had actually gotten off. And it was quite a decision. Of course, we had to sit at the panel and then we said, you know what, let us just get the instrumentation out. Let's observe and see what happens. And she was happy with the results, the pain was less, so she went into rehab. So, as my colleague said, the issues of feedback surgery, you will never know whether what you're going to do is going to the patient or not. You may operate many times the case that we saw yesterday, you don't know what you're going to end with the surgery. Whether you're going to end up with just putting in implants for pain or anything like that, I don't know. Because it's a very big thing that you have to think about all the time before you subject your patient to the surgery.
All right, thank you. We're going to move on to the next. We're going to move on to the next case.
Next case.
So fast. Oh, she can't mic this. Yeah.
So, one more case. This was a young. Let's go back. I'll start with this. Yeah. So this was a relatively young woman. I think she was almost 50. She's had lower back pain for at least two years, 2.5 years, and it got so bad in the last 8 months that she developed symptoms of L5 radiculopathy pain on the right side, on the outer side of the leg. And because of the back pain, she was put on opioids about 1.5 years ago. And the pain is normally, she described the pain as the pain increases during activity, walking, when she lies down, she has no pain. It's only during activity. So these are the pictures which are done with the colleagues in the pictures which are done outside the hospital. So this is what she presented with. This is there. Anybody, maybe the residents again, anything you see which looks kind of suspicious on these pictures.
Could we ask more history?
Yes.
What side is the pain on?
The pain, the L5 is on the right side. She developed that a few months ago. Let me just go back. There is I think this one was like, this one was like that. The pain was, the main pain was in the lower back, and like 8 months ago, she developed pain on the leg, on the right side of the leg.
You mentioned pain when she walked. How far did she walk for the pain to start?
When she presented, when I saw her, she could maybe walk for about 10 minutes, and then she just had to sit down or just take a break. And she was on opioids, so she still had pain under opioids. Yeah.
Flexion and extension.
No, she had no motor weakness, no deficits, no numbness.
No, he asked flexion and extension of the lumbar.
Mobility.
Yeah, she had pain. She could do it, but she had pain. When I looked at her, she had pain when she flexed. And when she came up from flexing, she had pain in the lower back.
How dynamic films?
Yeah, I have those. So the next, for the residents, I mean, what would be the next investigation that you would think of? I think. Yeah. All right. So we did that. Those were dynamic X-ray pictures. There was really nothing. There is something there's some suspicion that something that you will see which is suspicious, but the segments were all of the images stable. Yeah.
Is it very tilt?
Sorry.
The next slide has very tilt, right?
It just a little bit, yeah.
The pelvis is tilt.
Yeah. So what would you suspect? What would the next line of, or what would you do after this? What investigation? What?
I think I would calculate the angles of mechanical angles of pelvis and
Yeah. Well, I don't know about, okay, in Germany, for neurosurgeons, we rarely do that. I don't know about how it is in the US. We rarely go in that direction, so I don't know, you guys do that. I mean, for us, the next stage was to do a CT scan.
Correct.
Yeah, that's what we did. So, that was the CT scan. And that's also for the residents in the house. What do you see?
Harley
Any volunteers?
Harley
Harley.
Is a fracture
Yes.
what kind
Which area?
of the
Give him the microphone.
Yeah, he walks over here.
He walks over here.
So,
Just
can you, Khalid, when you're going to describe the image, you say this is a CAT scan long arm.
The cycle view. There's a fracture. There's a past fracture there.
Yes.
That's right.
Yeah.
Don't hurt it.
Yeah, so there's
Say
a
like
past
you mean
fracture there.
What?
Say like you mean it, you guys.
Dr. Patel, let him speak. Come on.
Yeah, so there's a fracture there. I think that's what's the cause of our pain. So,
Yeah.
so that could probably explain the symptoms.
That's right.
Yeah.
So the thing is, she was walking around with the MRI for 2 years. Yeah. She went through different pain specialists. So I think this just shows how important it is to, sometimes just if somebody has pain for 6 months, like just take the patient seriously and go the long way. And because this was really difficult, even on the T1 MRI scans to see. So now we have the fracture, which I think is a stress fracture because she's hyperlogic. So you have a fracture, you have back pain, but if you go back to the MRI scans, nowhere you see the compression of the L5, on the imaging. So the question is, do we operate? Do we do anything? And if we do, what do we do? Yeah.
Probably read the front.
It's usually been total fusion, not just fixation.
Also pretty much from
But she has been, you're not seeing the images, you don't see any compression of the L5. So,
the indication.
It's on the right.
it's on the right side. You lose that.
Of course, the next question, if you do surgery, what surgery are you able to do? I hope you're thinking, yes.
Yeah. Because every structure you need to install it, fuse it. Then is the filler going to resolve the pain on the back? No.
Yes.
Then what are we doing? If the main concern is the back pain for 3 years, and if it's the leg, then you will observe if it's worse than maybe that's the indication.
Okay, just to the back pain has been there for 3 years. The leg pain is also significant. It's very painful, and she's under opioids. Yeah. So any other take on that from the audience? Anybody else?
Another, you try to, what was that letters you use, PTR, or what we say the ESI?
What was that?
What we call it, epidural steroid injections. I don't know if you guys call it.
The one directly to opioids, she was on morphine. Yeah, so they're really there, but the one thing they did try, I think she had facets done, but there wasn't really any improvement.
Yeah, I would start with the L5 selective nerve injection, fracture site.
Yes.
See if that improves pain. That could give you diagnostic information and therapeutic advantage as well. She's not really angiosensing there right now.
Okay.
And it's unilateral cross structure, correct? I didn't see the other side.
Bilateral.
And I'd start with that first, I'd see how Dr. Gallagher cares. Great. Watch it.
Okay. So just by a show of hands from the surgeons, I mean, how many people go conservative? Just directly conservative. 2 years pain, L5, okay, and how many people go directly to surgery?
Conservative surgery. And for this patient, my team knows, I say it every time, a stimulator is an option. So a spinal cord stimulator, and films are normal. If you're trying to help her leg pain, it's unlikely to help because the flexion extension films are normal, there's no stenosis. So she has a 2-year history of radiculopathy for which she's on chronic opiates, which eventually won't help at all. A spinal cord stimulator reversible option with lifelong coverage.
Okay.
So do you have to trial first?
Yes. So there's a process, but instead of applying medication, you thread the electrode up the spine. For back and leg pain coverage, the best coverage was electrodes to electrodes. New types of programming, we're doing it at T910. But you do that procedure awake. You over their pain they typically live, and if they feel like it's helping their pain day to day, you bring them back and you put both outpatient procedures. They each take about, the first one 15 to 20 minutes, the second one the permanent implant. Whereas with the fusion, there's no predicting the outcome, and the result is not reversible. If it's on the left side or a new pain in the foot, or you can remove it. They're very
You can mistake it, but because of the costs, we've had to leave it for only specific patients. So it was interesting that you said you do so. We don't do the per claims one. It will be interesting to find out how easy it is for us to operate through that. That yes would be a useful addition in terms of the service. So this for the residents, this service, the pain management part of things is available.
So Dr. Waneke would go directly to surgery. So
Yeah,
some wax into the process. That's fine. Yeah. You have, for this particular one, done your scans and see there's a fracture, but one of the pain management is cervical decompression, probably process of pain management that's going on. That's not available in any, even at the National Hospital, it's not available. So for this kind of patients, and for patients who don't have the luxury of
So for this patient, I would say that I would follow pretty much the paradigm that Dr. Patel laid out before deciding about surgery. So give a trial of conservative management in terms of either a framinal steroid injection and or a pars injection. And as you mentioned, it ends up being therapeutic. Then there may be a subtle instability that's just not being caught by the x-rays. Got to remember the MRI and CAT scan are done supine. So you're not going to see the listhesis necessarily. The x-rays, they're fair, but I can't say that you can always appreciate everything that's going on at the framinal level. You don't need a 3 millimeter dynamic slip to suggest that there's some sort of micro instability there. So I would work in that direction. And I've done many of these. If they get no relief whatsoever with any of that, I don't use surgery as a Hail Mary. It's an American term for last ditch, hopeless effort. I think at that point the morbidity of the surgery outweighs the potential benefit. But if you go through a pretty good workup and conservative available are all sorts of imaging that does show some subtleties that supine imaging.
Has said, and
I think that's an important point because with the imaging, the subtle instability, we have a blind spot, the thing we just cannot see. So, and that was our thought process, yeah, so that the MRI was done supine. We see a little bit of the tilt in the X-ray, the side X-ray, the lumbar X-rays, and we were thinking that direction. But just you want to know.
Just one other comment. I don't know if you guys have noticed this. So the critical part of the history is when does the pain start getting worse? A lot of these spondylolistheses start to slip at the end of the day when their back starts loosening up. They wake up very stiff and the muscles are holding them in place. So we started collecting data in Boston where we've been doing our dynamic films around 3 or 4 p.m. After the patients had a long day of walking around, loosening up. We found we do x-rays in the morning. They have minimal slip, no gross instability. We're finding instability at the end of the day as their muscle, their paraspinal muscles loosen up. So I started in my clinic now. I used to see my new patients in the morning. They come in the morning, get their peripheral forcini, their steroid films, electrodynamic films. I push them to the afternoon now, so they have their normal day, loosen up, then they get their dynamic films, and I'm catching more slips now. Okay. And then also, like Dr. Gallo said, standing films are give you a lot of valuable information as well now. When you're lying down, the flexion extension of the little towel roll is not adequate in my opinion. You have to be standing, bend forward, bend backwards, extension. You have to be standing up and bend for me.
Were those standing?
Those are standing.
Those were standing.
Yeah, I'm just giving in general.
To start answering the question that was asked, the first thing that I ask a patient like this who's got a 2-year history, who's gone through conservative management, who's on morphine, is what do you want? What is your expectation? Because as we've all mentioned, surgery is not reversible. If I have a patient, and to allude also towards Dr. Patel's question, who says, I want it fixed, that's a concern for me because I can't fix it to their satisfaction. We're not 18. I don't have fairy dust that I can give you to make you 18. So you're not going to be the way you were. If I have somebody who comes in who is non-functional, cannot perform their job, and has reached a point that their life has been so affected, then we start going down the surgery trail with the full awareness of what can happen with surgery. Because as we've all heard and we all know, and we saw with Victor's wonderful case yesterday, is back surgery brings more back surgery. But if you have somebody who clearly has a reasonable expectation, who has a good historian, then the way I think this case is going to go is not unreasonable. So I don't want to say what I would do, but I think, there's something to be said about doing surgery.
So this was my thought process. We had the thing is, the reason we did not do any injections was she was. So we were kind of that's why we were reluctant on giving injections. So the thought was the progressive lower back pain. We took that as an evidence of the instability, the sudden instability we were not seeing on the images. So we decided that we'll do surgery, and then the question was, what kind of surgery? Would you just do a foraminotomy, although there is nothing, you don't see any compression of the L5, or would you do foraminotomy and fusion? And if you fuse, let me just go back to the CT scans. How far would you go? So I don't know about you guys, but for me, this stuff sometimes keeps me awake. So when you're thinking, okay, how far would you go when you want to fuse this? So any takes on that? So we decided for surgery. We decided we needed to do surgery. So what would you then do?
So the question is, how much to fuse?
How much to fuse? Yeah.
So for me, I would probably try to just keep it simple, and do 5-1. I think back to your use true sagittal balance as the indicator that she is hypolordotic. You want to do the skill set that you want to get so that you can impart that upon them, because it's really become an important part of even neurosurgical practice now. Okay. I don't want to call it an orthopedic thing, but it's a spine thing. Take care of the segment that's disease.
We'll go further than the affected segment. Maybe one will fuse from L4 to S1. Is there any question? Would you fuse from L4 to S1 or just L5 S1? Keep it simple as Dr. Gala says.
I want to come back to the previous point from making. Will let's say MIS foraminectomy alone, will it be a fast track for this patient?
That's fusing.
No, just to decompress MIS minimally invasive surgery without doing much and see what the result is.
What's worse, the leg or the back pain?
Most important.
I did the surgery and I just did, I fused L5 S1, and interesting enough, intraoperatively, the L5 on the right side was. So I think the thought process at the beginning of the surgery, the L5 pain subsided completely. She had no pain in the leg. The back pain reduced just a little bit. So we're still controlling her, but this is what we ended up doing. And I just thought this was a good example of a case where you split on the decision, where you find different opinions to it. So that's it. Any more questions?
Doing nerve monitoring prior.
The leg pain got there immediately, sorry, but the back pain was just a little bit, not really, So that it's fresh. I think I did the surgery, I think it's about 3 weeks ago. So she's coming back in about 4 weeks.
I think for these cases, expectations have to be laid out very well. And the patient needs to know that there's a chance that nothing is going to improve. For me, I do the squint test. if I can't see the pathology from across the room, you're not getting surgery. But this is a person who benefited from surgery. So I think that there's. Well, the radiography has gotten better.
She was really
well for now.
We had her for about 10 days, and she really did improve. We actually already think she
Use ibuprofen infusion.
we do. Yeah, it's different. Again, there's a discussion on that. Yeah, so she did benefit. Yeah.
Any other questions? Thank you. Thanks.